So I'm going to continue the renal theme of the day, talk about some renal topics in pediatrics. So the outline is going to be two larger cases. We're going to go through the diagnosis, the differential, their workup, management, and the prognosis. And then, since I feel like it's always a question in the PDR, we're going to do some 3 short cases on whether you're going to get a UA or not. So this is our first case. Is a 5-year-old male. He has no medical problems. Came to the ER for abdominal pain for the past 3 days, and then mom noticed this rash, so she brought him to the ER. Abdominal pain is diffuse, rash is not painful or itchy, never had this rash before, no current fever or viral symptoms, no vomiting, diarrhea, had a recent viral illness about a week and a half ago, no known sick contacts, no travel, no one else in the house has this rash, normal PO intake and urination per mom. On review of systems, you also get that he's kind of having right knee pain. And no kind of black or bloody stools. On physical exam, afebrile, heart rate's 103, saturating 100%, not tachypnic, and blood pressure is 130/86. He's playful, interactive, lungs are clear, abdomen soft, non-tender. Soft, but grimaces kind of with deep palpation throughout, moving all of extremities, and you take a kind of look at the rash. Just wanted to ask if anyone kind of notes anything abnormal in his vital signs. And I cannot see the chat, so if anyone could. So this is the rash that you see. So does anyone have a differential? Maybe, oh, good. So Alice kind of got to it, but I was saying that maybe this would be, I don't know why. Sorry, it's locking me from changing my slide. So maybe this rash would have been maybe a little bit more obvious to people, but I wanted to show a rash kind of in our population and what it would look like. So yes, this is HSP. So this kind of occurs between 3 and 15 years of age. The peak incidence is around 4 to 6 years of age. It's a male predominance. It rarely occurs during the summer months because it's usually preceded by a URI. It can be preceded by streptococcus, RSV, flu, or norovirus. Those are the most kind of common ones. The classic tetrad for these patients is they're going to have some sort of abdominal pain, arthritis or arthralgia, and they have this palpable purpura that you kind of see usually on the lower extremities without thrombocytopenia or coagulopathy, and the involvement of the kidney, so kidney disease. So the rash you typically see is, it starts off like erythematous, macular, or urticarial wheals, sometimes these targetoid lesions, but it all should be non-blanching. Sometimes can be described as pruritic, but it's rarely painful. It can evolve into those typical ecchymosis, petechiae, and palpable purpura. It's typically gravity dependent, so in the lower extremities, but in toddlers who aren't like walking as much, kind of can be in their buttocks, and then can even be seen in their face, trunk, and upper extremities in non-ambulatory children. You also can see some localized subcutaneous edema with it, and that also will be in more kind of dependent areas. So for arthralgias, 84% of patients have arthralgias. It's usually transitory, migratory, usually in the ankles and knees, and even younger children may kind of refuse to ambulate due to the pain. About 50% of patients will have GI manifestations. These can be as kind of simple as nausea, vomiting, a paralytic ileus, all the way up to the more extreme things as GI hemorrhage, bowel ischemia, necrosis, intussusception, and bowel perforation. Typically occur after the rash, but they can occur before. So it can kind of be hard to diagnose when they're just having the GI symptoms before the rash appears. GI symptoms are caused by the submucosal hemorrhage and edema, which is kind of shown in the ultrasound on this side of the screen. But intussusception is the most common GI complication. So if you're at all concerned with the history that the patient is presenting with intussusception, they should definitely get an ultrasound and have close kind of monitoring. And the reason why this occurs is because the edema and hemorrhage can actually act as a pathologic lead point. and lead to intussusception, usually in the small bowel. So what are the kind of kidney manifestations of this? So about 20 to 54% of children have some sort of kidney involvement. It's actually more prevalent in older children who get it around 9 years old. You can see some hematuria with or without red blood cell casts and mild to no proteinuria. Um, if there's any presence of nephrotic rage proteinuria, elevated creatinine, or hypertension with hematuria, there's an increased risk of this kind of progressing. Risk factors for that are, again, older age, the severity of the GI symptoms. They kind of have persistent purpura on exam. If this is a relapse or a second kind of episode of this, elevated white blood cell count, elevated platelet count are also associated with this, as well as an elevated ASO titer and low C3. Other factors, also angioedema, CNS involvement, or even delay in diagnosis kind of dictate that there's going to be a more kidney involvement and kind of worse prognosis. Rarer manifestations to kind of look out for is that these patients can sometimes have pain or tenderness involving the testicle and scrotum. This may even mimic testicular torsion. If you're obviously concerned for testicular torsion, you should get an ultrasound in these patients as well. And also rare, but can occur, these patients can have CNS kind of involvement, headaches, seizures, encephalopathy, even hypertensive emergency. They can present with deficits, ataxia, and in extreme cases, intracranial hemorrhage. And in those cases, you should be obtaining a CT head. So for the workup for these patients, a lot of the times these are very well appearing children. They maybe have no abdominal pain. They only kind of have the rash and some possible joint involvement. You may not even need to get labs on these patients. May only need a urine analysis just to look kind of for hematuria and proteinuria. Make sure you're not like in a like nephrotic range, and they can kind of be monitored with a UA and blood pressure weekly by the PCP. In a non-well appearing child, though, with abdominal pain, you should get labs, CBC, COMP, PT, PTT, ESR, CRP. You may see in the literature about obtaining an IgA level, but this is more for like an inpatient kind of workup or a renal kind of workup. But it is good to note that higher levels of IgA are kind of associated with renal involvement and poorer prognosis. In these children, they should have normal platelet counts, coagulation studies, and that can help with your diagnosis that this is HSP. And then again, like we talked about, any patients that are having abdominal symptoms that are consistent with intussusception, they should get an ultrasound. And any abdominal pain consistent with obstruction or peritonitis or perforation, again, surgical consult, ultrasound, possible CAT scan. And those children with acute mental status changes, CT head. So all purpura is not HSP. So you should think of other kind of differentials. You should think about septicemia, Neisseria, ITP, HUS, even leukemia or coagulopathy. So that's why it's really important to kind of obtain the PT, PTT, and platelet kind of studies in any non-well appearing child, because you're kind of looking for signs that they have a coagulopathy or possibly leukemia. For those other differentials for normal platelet and coagulation studies is the picture of this infant here. This is acute hemorrhagic edema of infancy. It's actually a leukocytoclastic vasculitis. It occurs between like 4 months to 2 years. It's actually self-limited. They may have fever. They have this purpura and ecchymosis, very pathognomonic at the ears, and they have this inflammatory edema. This actually resolves within 1 to 3 weeks, and kidney and GI involvement is very uncommon. There's also another hypersensitivity vasculitis that has fever, urticaria, lymphadenopathy, and arthralgias, and those typically don't have any kidney involvement. It's also important to kind of consider in these patients any other kind of secondary cause. So whether that's like SLE or juvenile idiopathic arthritis, and those may be patients where you consider getting complement levels or ANAs or anti-double-stranded DNAs in those patients. This is just a kind of quick flow sheet to kind of go through. Again, IgA vasculitis or HSP is a clinical diagnosis. So if they have that classic rash and they have 2 of the 3 additional clinical features, you can pretty confidently say that this is IgA vasculitis. If they kind of just have the classic rash, but not the other additional features, this may be something that they should get a biopsy kind of from derm. Um, and then if they only kind of have the additional clinical features without the rash, this may be someone that you need to consult nephrology for. They will consider like a kidney biopsy or further kind of workup. And again, if they don't have the rash and they don't have any of these kind of other associated symptoms, you kind of should be steering pretty far away from HSP and kind of be working up their abdominal pain and arthritis and arthralgias for something else. And then so for management for these patients, patients who cannot maintain their hydration with oral intake, which we kind of know in pediatrics, they should all be kind of admitted. Any severe abdominal pain, concern for GI bleeding, any mental or respiratory changes, severe joint pain that kind of affects their ability to ambulate or function, and then any sort of kidney involvement, which would be elevated creatinine, high blood pressure, hospitalization. Chart, you can see they start off with the severe abdominal pain that limits their oral intake, and so those patients should all be admitted. You should consider methylprednisone as they're not tolerating orally, and then monitor for abdominal complications. If they're kind of tolerating orally, but they're still having severe joint pain and they're having adequate oral intake, then you can treat with oral prednisone and also admit them. If they're having still kind of inadequate response, they may want to change over to an IV form. If they're having kind of not severe abdominal pain, good oral intake, not severe joint pain, maybe it's just mild to moderate pain, no signs of active GI bleeding or glomerulonephritis, they can be kind of treated with naproxen or ibuprofen. Any signs of GI bleeding or glomerulonephritis, they're going to kind of manage with Tylenol. So for our kind of management, most of these children, like I said before, are pretty well appearing. They may not even need lab work. They will recover spontaneously and can be cared for in the ambulatory setting with kind of weekly UAs and blood pressure monitoring. So the care for them is pretty much supportive with hydration, rest, symptomatic relief, bed rest, elevation of the areas of edema, pain medication, Tylenol, Motrin. In studies, NSAIDs have really shown no kind of evidence to suggest increased risk of GI bleeding in these kids. Glucocorticoids are kind of controversial in certain situations. They do shorten the duration of abdominal pain, but they have no kind of impact on the clinical course, and they don't affect the risk of developing intussusception or kidney involvement. So really, they should be reserved for kids who are having such severe abdominal pain that they're not tolerating orally. They have such significant kind of arthralgias that they're not walking, or then kids that have kind of kidney involvement. They recommend prednisone 1 to 2 mg per kg. And if they can't tolerate orally, like we just talked about before, methylprednisone alone. If they have IgA nephritis with the marked proteinuria or impaired kidney function, they should receive glucocorticosteroid in their acute episode and potentially follow up with renal, and they may consider a renal biopsy as it's the best indicator for prognosis. So for prognosis and follow-up, so most recover spontaneously, can be cared for again in the ambulatory setting. And the initial episode of HSP usually resolves within a month. 2 out of 3 kids have no recurrent episodes. 1/3 recurs within 4 months, and those courses are usually milder and shorter, and the recurrence is actually associated with a more severe initial episode of HSP. Morbidity in the initial phase is related to intussusception or so don't miss that in these kids. But long-term morbidity is associated with kidney disease. 90% of patients will develop it within the 2 months of onset and 97% within 6 months. UA and blood pressure monitoring weekly or biweekly at the primary care or the pediatricians, and then for the first 1 to 2 months, and then once the disease is inactive, monthly, and then every year, every month until 6 months to a year. Again, these kids may never need blood work. Then outpatient kind of workup if their serum creatinine is only kind of obtained if they have significant or persistent urinary abnormalities or elevated blood pressure. And that's kind of when they should be referred to peds nephrology and obtain kind of blood work. So returning to the case, patient was tolerating PO, ultrasound was negative for evidence of intussusception. Labs had normal platelets, normal PT, PTT, normal creatinine. He had significant proteinuria on urine analysis, so decision was made to, with the hypertension, to admit for 24-hour urine collection and nephrology consult. Uh, his 24-hour urine collection showed more than 1 gram per day, and so he was given IV methylprednisone for 30 mg per kg for 3 days and discharged on prednisone with peds nephro follow-up. It is possible, kind of, in this patient, if it's during the day, you can kind of obtain a renal consult. They can make a plan for a 24-hour urine collection and close kind of follow-up. But in most cases, when they see kind of any sign of hypertension, proteinuria, they're going to be pretty aggressive about admission. Okay, so just switching gears, we're going to go into a UA or no UA case. So this is a 14-month ex-full-term female, no medical problems, came to the ER for fever, funny breathing, congestion, and fatigue for 1 day. Mom says decreased PO, but still made 3 wet diapers today. 1 episode of non-bilious, non-bloody vomiting. Was seen in the ER actually 4 days ago for fever, Tmax 101, and congestion. Defervest was sent home. Cepheid was set, and results indicate RSV. Repeat vitals in the emergency room today are 103.2, heart rate 162, tachypneic to 42, saturating 100%. Blood pressure 87/43. She appears tired. She has moist mucous membranes, positive for congestion, increased work of breathing with diffuse wheezing throughout, and abdomen is soft and non-tender. So she's given Tylenol, Motrin, a saline neb, but she's still pulling into tachypneic without fever. So the plan is to admit or OBS for bronchiolitis. You call the peds floor and they ask if you considered getting a UA. Would you consider getting a UA in this patient? So slightly controversial, but maybe you should consider a UA in this patient. The rate of UTI in febrile infants less than 3 months ranges from like 4 to 20%, and from 3 to 36 months is like 0 to 7.4%. So in meta-analysis, the rate of UTI in healthy febrile infants is about 3.3%. Early studies have shown that there's not a relationship between UTI and bronchiolitis, but in those studies, the definition of bronchiolitis varied greatly, and the definition of UTI also varied greatly. But in a more recent study with patients with acute bronchiolitis that required hospitalization with a clear UTI with UA with pyuria or bacteria with a culture greater than 50,000 CFUs, came by cath or suprapubic aspiration, 10% of these patients had UTI. 13.4% when the virus detected was other than RSV, and 6% when the virus was RSV. So double the overall rate. So the pathophys for this is unclear, but it's thought that the viral infection is significant enough to disrupt the epithelial border to cause bronchiolitis, that similar changes are happening to the urinary tract and the immune system. Therefore, some clinicians would advocate for obtaining a UA in this patient who's going to be hospitalized for bronchiolitis that kind of seems to have had been doing kind of well before and then kind of progressed and got worse with higher fever. But again, they should be individualized to each patient, and it won't kind of change your dispo. This patient still needs to still needs to be OBS for bronchiolitis. And if the patient's not improving, they can consider it on the floor. So second case for UA or no UA. This is an 8-month ex-full-term male with no past medical history, presenting for fever since yesterday, Tmax 103. Mom has been giving Tylenol, Motrin, no nasal congestion, cough, vomiting, diarrhea, no history of UTIs in the past, no recent travel, does attend daycare. Exam here is 102.7, heart rate 157, respiratory rate 33, saturating 100%, appears well, playful, interactive, moist mucous membranes, no congestion, lungs are clear, belly soft and non-tender, circumcised, and there's no kind of rash. So you can use a source for this. Would you get a UA or not? So I think Laddie's bringing up UTI calculator. So this is actually based on the UTI calculator, no kind of UA. This is a circumcised male patient, less than 2 days of fever. Even without a source, with no history of UTI, he's kind of low risk for UTI. Most likely will develop other symptoms of viral URI in the next day or so, but it's important that this should only be used in a well-appearing child. Management would change in any unwell-appearing child, and return precautions should be given for fever of more than 5 days, especially without manifestations of other symptoms. Okay, so going into our second larger case, this is a 4-year-old male with no past medical history, presents for swelling to bilateral eyes for the past 3 days. Mom notes decreased PO and fatigue. Went to urgent care 3 days ago, was given Benadryl, but is not resolved. Had a recent viral infection 1.5 weeks ago. No fever, no trouble breathing, no vomiting, no diarrhea, no urinary symptoms. On exam, these are his vitals. Appears tired, bilateral paraorbital edema without conjunctival injection, no discharge. Extraocular movements are intact, lungs are clear, belly soft and non-tender, and 1+ kind of bilateral lower extremity edema. So anyone have a differential for this case? So yes, so someone saying minimal change disease. So yes, more broadly, nephrotic syndrome, most likely minimal change disease. So the clinical manifestations for this are fatigue, malaise, decreased appetite, weight gain or facial swelling, abdominal swelling, foamy urine, and edema. Typically, the edema is periorbital. In the reclining position, can have back and sacral kind of areas of edema. It's usually non-erythematous. It's soft. It's pitting, but some patients can go on to develop anasarca. And then you're going to have nephrotic range proteinuria. So this is greater than 50 mg per kg a day, or in a 24-hour urine collection. But we're not really going to be able to get that in the emergency room. So in a spot urine sample, the urine protein to urine creatinine, it's going to be greater than 3. And then hypoalbuminemia, so less than kind of 3 grams per deciliter. We're going to focus mostly on primary nephrotic syndrome. So that's, again, minimal change disease, or more rarely, but possible primary focal segmental glomerulosclerosis. But it's important to remember that there are secondary causes of nephrotic syndrome. So don't kind of forget those. Those are your SLE, infections, vasculitis, sickle cell disease, and there's a long list of genetic kind of causes. So the epidemiology for this is 90% of cases are between 1 and 10 years old. It's most commonly minimal change disease, which is about 75 to 80% of primary nephrotic syndrome pediatric cases. It's more common less than 6, and it's 2-to-1 kind of boys to girls predominance. There is a genetic component to it, so there is increased incidence among family members or affected siblings, so it might be something to kind of ask. Infant nephrotic syndrome is defined as between the first 3 months to life to less than 1 year. There's typically a genetic component to this, and there's poor outcomes. It's not usually related to minimal change disease or even PSGS. Rare manifestations that you can see with nephrotic syndrome are hyperlipidemia, hypertension. It's pretty infrequent in minimal change disease. Hematuria, it's rare, but you can see it in about 20% of cases. And then hypovolemia, which as ER doctors, we kind of all know what to look for: tachycardia, hypotension, peripheral vasoconstriction. Again, thinking about other things on your differential, any kind of palpable purpura rashes, should be thinking more of HSV or vasculitis. If you're seeing a malar rash, adenopathy, arthritis, weight loss, think about lupus. If they had a recent strep infection, think about GAS. And then any sort of dysmorphic features or ambiguous genitalia, you should be thinking of a syndromic or genetic cause. And then also any congenital infections, HIV, hepatitis, syphilis. The workup for these patients is, again, obtain a urine analysis, obtain a urine protein to creatinine ratio. These kids should all kind of get blood work, looking at their kidney function. They usually have normal kidney function, but it can happen that due to intravascular volume, they can develop AKI, especially with concurrent infection. These patients you should obtain them complement levels. They usually have normal complement levels in idiopathic nephrotic syndrome. And if they have kind of low C3, you should be thinking more of post-strep, or low C3 and low C4, you're thinking more of lupus. You should get complete blood counts for these patients, as they have increased risk of infection. And serum lipids are sometimes also recommended, as it's sometimes a characteristic feature. Again, children less than 1 year of age, especially less than 3 months, they should undergo genetic testing. They may not even recommend empiric treatment with glucocorticoid steroids for these patients, as they don't really have a role in genetic disorders. Ages 1 to 12, they don't really need to go under any genetic testing unless there's kind of atypical features. And then less than 12, it's usually still primary nephrotic syndrome, but they may recommend a kidney biopsy. if they're not kind of responding to glucocorticoids. So complications in these patients, they can have pleural or pericardial effusions, ascites, anasarca. They are predisposed to thromboembolic events, so PE, DVT. They can also be hypovolemic with signs of tachycardia, have hypertension and pancreatitis. They are also at increased risk of infections due to reduced IgG and ability to make antibodies, as well as the fact that they're on chronic steroids, making them immunosuppressed. So the management for these patients, all these patients should be admitted, especially with their first episode, as this is a lifelong condition and it will assist with parent education and management. If there's any signs of hypovolemia, you should give fluids. If there's severe edema and normal or increased intravascular volume, you can consider furosemide. You should be looking out for, again, any of these kind of complications that we discussed. So management of infections or possible thromboembolic event. And then criteria for starting steroids is anyone who's older than 1 and younger than 10 years of age, no signs of hypertension, gross hematuria, or marked elevation in the serum creatinine. They should have normal complement levels and no extrarenal symptoms. So like no mal or rash or purpura that would lead you towards another diagnosis. 90% respond to steroids if they have minimal change disease. And 15 to 20% of FSGS still also respond to steroids. So even if we don't know if it's minimal change or FSGS, initiation of steroid treatment is going to help most of these patients. There are some patients that they are steroid resistant. That's only about 10 to 20%. And these patients have an increased risk of developing ESRD. Typically, it's recommended as oral prednisone is 2 mg per kg per day. So again, the prognosis for these patients, remission usually occurs within the first 4 weeks, and that's kind of the disappearance of the proteinuria. And then about 10% will need an additional 2 weeks of steroid therapy. Again, there are steroid-resistant children who may end up requiring a biopsy to make a definitive diagnosis. Most children will grow out of this in their adulthood, but children can have relapses in the emergency room and they have a diagnosis of nephrotic syndrome already. So returning to the case, urine protein to urine creatinine ratio was 4, albumin level was 1.5, a CBC showed thrombocytosis, electrolytes in BU and creatinine were normal, complement levels were normal, admitted to the floor, started on prednisone, and nephrology follow-up with a weekly urinalysis was arranged. So for our last UA or no UA, you have a 30-month ex-full term male, no medical problems, presenting for fever for the past 3 days. Tmax 103, non-bilious, non-bloody vomiting for the past 3 days. Mom brought to the ER as not tolerating PO. Mom denies any congestion, cough, diarrhea, rash. He has a history of 2 UTIs in the past and had a renal ultrasound that she was told was normal. Attends daycare, no known sick contacts. On exam, febrile to 103.2, tachycardic, mildly tachypnic, saturating 100%. Normal blood pressure, appears tired, mucous membranes are dry, lungs are clear, belly soft, some suprapubic tenderness. He's circumcised and you don't see any rash. Should this child get a UA? And anything else you would recommend that this child gets? So Dante is saying UA, yes. Definitely a UA. And this child should get repeat ultrasound and then possibly avoiding cystourethrogram, as you might have some sort of reflux or UPJ as discussed in previous kind of lectures. So any child under the age of 2 with a febrile UTI should receive an renal ultrasound, but only 1 in 4 to 1 in 5 young children with the first febrile UTI will have a urinary tract abnormality detected on ultrasound. So any children should proceed to avoiding cystourethrogram if they've had 2 or more febrile UTIs, or if their first febrile UTI, they had any anomaly seen on the kidney ultrasound, they're had a temperature greater than 102.2 and a pathogen other than E. coli, or they're having any poor growth or hypertension. Just kind of remember these kids that are lost to follow-up and are having frequent UTIs, they should possibly be obsed or even or definitely get follow-up with imaging done. So in summary, HSP, remember the tetrad, the palpable purpura without thrombocytopenia or coagulopathy, the arthralgias, abdominal pain, and kidney disease. This is a clinical diagnosis. Mostly they're managed outpatient with supportive care. Rare cases require admission and steroids. Nephrotic syndrome, mostly minimal change disease. And remember, all periorbital edema is not allergies. The diagnostic criteria for proteinuria, hypoma,